Since the initial use of laparoscopy in the management of non-palpable testes in the 1990s, the use of laparoscopic and robotic surgery in pediatric urology has expanded significantly. This video will cover the proper technique for and other unique aspects of port placement for minimally invasive surgery in pediatric patients. This video will review unique aspects of pediatric anatomy relevant to port placement. It will then detail the open, Hassan, and closed varus techniques of entering the peritoneal space and achieving pneumoperitoneum, followed by a demonstration on placement of radially dilating ports. We will then discuss hidden incision endoscopic surgery via an alternative port placement configuration. And finally, we will cover fascial closure of port sites and potential complications related to insufflation. A unique aspect of port placement in pediatric patients is umbilical access. Umbilical access in young children is possible as the umbilical ring does not close until a few years after birth. When placing an umbilical trocar and insufflating in neonates, one must take care to avoid injuring the umbilical vein, which can result in bleeding or a venous air embolus. Extra care must be taken to avoid vascular injury in children, as the great vessels are closer to the abdominal wall in pediatric patients when compared to adults. Additionally, particular care should be taken to avoid the right common iliac artery, where it crosses the midline directly under the umbilicus. The relative laxity of the abdominal wall in pediatric patients should also be considered when choosing a technique for accessing the abdomen, as this increases the risk for bowel or vascular injury during port placement. Finally, one must also be aware of the intra-abdominal location of the bladder in children. The open Hassan technique can be used as a primary method of establishing pneumoperitoneum, but can also be used after pneumoperitoneum is established with a varus needle to place additional ports. First, 2 stay sutures are placed on either side of the umbilicus. Here we demonstrate an example of umbilical access. However, subumbilical access is also commonly used. The sutures are pulled up and elevated to provide countertraction. Dissection is carried through the subcutaneous tissue using electrocautery until the umbilical scar and rectus sheath are visualized. The rectus sheath and peritoneum are incised. Forceps is used to provide additional countertraction, and the peritoneum is bluntly entered using a hemostat angled at the anterior abdominal wall. Once the surgeon feels that they have entered an open cavity and the abdominal viscera are visualized, a trocar with blunt inner cannula can be advanced into the peritoneal cavity. This is followed by a water drop test to confirm entry into an open cavity and insufflation. An umbilical incision is sharply made using a scalpel. The varus needle, which is aimed at the pelvis at 30 degrees, is advanced until at least 1, but possibly 2 pops are felt. The needle should feel like it is in an open cavity with no resistance. A 10 cc syringe with 5 cc of sterile saline is then attached to the varus needle and aspirated to confirm positioning while monitoring for the return of blood or bowel contents. 5 cc of saline is then instilled. If there is no resistance, the syringe is then aspirated to ensure that no saline returns, indicating that the needle is not in a closed cavity. The syringe is then removed. A drop test is then observed to confirm that the remaining fluid has traveled down the needle. Insufflation is then started while monitoring that there are not high pressures with low volumes. Here we demonstrate the insertion of a radially dilating port. These are the components of the radially dilating port system. Once pneumoperitoneum is established, a varus needle with a 3 mm sleeve is inserted into the peritoneal cavity as previously described. A 5 mm dilating cannula with an inner obturator is inserted. The outer sleeve is grasped while the cannula and obturator is angled anteriorly. A constant twisting motion is applied while the cannula is advanced. A 5 mm port site can be expanded to accommodate a 10 mm port by removing the cannula while leaving the sleeve in place, followed by insertion of a 10 mm cannula and obturator in the same fashion. Here we describe port site fascial closure using a groove director.
Children, especially those younger than 5 years old, are at higher risk for port site hernias than adults. Due to thinner abdominal walls, defects created by angled port placement in children are not offset as much as in adults and provide less protection against hernia formation. Fascia should be closed for all port sites in children due to this increased hernia risk. The groove director is advanced through the port site below the level of the fascia and angled anteriorly. The needle is then advanced through the fascia on one side of the port site until it encounters the groove director. It is then rotated along the groove and the suture is pulled through. The groove director is rotated 180 degrees. The needle is guided by the groove and passes through the fascia on the remaining side of the port site. The sutures are then tied to closed fascia, followed by skin closure. The groove director both helps guide the needle and also protects against inadvertent injury to the abdominal viscera below.
Alternative port placement configuration can allow for hidden incision endoscopic surgery. Pneumoperitoneum is achieved via the closed varus approach described previously. A 5 mm port is placed umbilically to allow for visual placement of the larger robotic working ports, and then exchanged for a working port. A working port, camera port, and 5 mm Cystin port are placed at the level of a fan and steel incision. This technique can be particularly desirable in pediatrics as it produces non-visible scars. Complications related to port placement can often be secondary to physiologic changes that occur during insufflation. Patients can have a vagal response during insufflation resulting in bradycardia. If this occurs, surgeons should open ports to reduce intra-abdominal pressure, consider administering fluid to increase intravascular volume, use a slower rate when reattempting insufflation, and convert to an open approach if bradycardia persists with a reasonable insufflation pressure. Pneumoperitoneum can also cause decreases in cardiac output. Trendelenburg positioning can counteract this by increasing venous return. Here we show recommended insufflation rates and working pressures for patients of various ages.